Well, good afternoon, everybody, and thanks again for joining us for the final segment of the CPOP-MAPTA webinar series focused on the confluence of the opioid epidemic and the COVID-19 pandemic. My name is Matthew Rubin, and on behalf of both CPOP and MAPTA, we appreciate you joining us this afternoon. Over the course of the last 5 weeks, we've seen an incredible level of interest in the topics discussed and the national leaders that have joined us for these really important conversations. Throughout the duration of the next hour, we'll wrap up the series focused on efforts to remove unused and unwanted prescription drugs from the home. Given self-isolation and quarantine measures exercised over the last several months, the main point of care for individuals nationwide has really become the home, which is also the location for greater amounts of prescription drugs and subsequent risks for misuse, abuse, and diversion. At the outset, a few housekeeping items that we'd like to cover for this group, especially those that are new to the session. For the best viewing experience, we recommend closing any programs or browser sessions running in the background. Since webinars are bandwidth intensive, closing any unnecessary browser tabs will certainly help to conserve some of that bandwidth and make for a more seamless streaming opportunity. If you're experiencing any technical difficulties, please visit the webcast help guide by clicking on the question mark icon near the bottom of the screen or reference the technical tips. These resources should cover many of the common technical questions that might arise during the duration of today's webinar. The webinar console that you're currently looking at can be completely customized to your liking. You can minimize, resize, or move any of the open windows. At the bottom of the console, multiple application icons. If you have a question during the webinar, you can click on the Q&A icon at the bottom of the screen to submit your questions to the presenters. We'll do our best to answer these during the duration of the webcast, but if we do run out of time, your question will be addressed via email. I also want to call attention to the resource list that's located on the left-hand side of your screen. There you can download a copy of the presentation slides from today and access additional resources. For more information on the entire series on demand, please visit www.cpoponline.org or reach out to myself. We're pleased today to be joined by a long-standing leader in the fight against the opioid epidemic and co-convener of CPOP dating all the way back to October 2014, General Arthur T. Dean, Chairman and CEO of the Community Anti-Drug Coalitions of America, or CADCA. General Dean is going to provide a few opening remarks at the outset of today's session and then turn the call over to this afternoon's moderator, Ms. Judy Lund-Person of the National Hospice and Palliative Care Organization. With that, General Dean, thank you for your continued leadership in this space and happy to turn the webinar over to you.
Matt, thank you very much, and thank you for the opportunity to be a part of this series. I want to express my thanks to everyone for joining us on this afternoon webinar, the last in a series of 4 events focused on the impact of the COVID-19 pandemic on the opioid crisis. Over the previous 3 sessions, we've taken a deep dive into areas of digital healthy as well as telemedicine. We talked about medication-assisted treatment and most recently overdose reversal medications. Each of these hit on the core priorities for our webinar sponsors, CPOP and MEPCA, and highlights the areas most significantly impacted by the confluence of these 2 public health threats. You've heard this before, but the data available continues to support our ongoing efforts to develop a comprehensive opioid response during our current circumstances. Opioid overdoses, unfortunately, in 2019 rose by some 4.8% over the previous year. Erasing advances to reduce overdose deaths achieved in 2018. The unfortunate news is that those numbers seem to rise to a greater degree during the first quarter of 2020 as we now deal with COVID-19. CPOP, the Collaborative for Effective Prevention of Prescription Opioid Policies, was formed more than 5 years ago to develop, disseminate, and advocate for a balanced solution to this crisis. With more than 80 participating organizations from all sectors, CPOP remains focused on this mission. Mothers Against Prescription Drugs Abuse is a growing grassroots movement among families who have resolved to turn their experiences into positive change with loved ones and across our society. Together, CPOP and MEPCA brings enormous reach and expertise to these challenges. Before I turn the discussion over to my dear friend Mary Bono, I want to also indicate to you that CATCA has been working diligently in this space as well over the past few years, and working with significant partners. We have distributed over 1 million of the deterrent disposable pouches in 18 states across the United States. And working with our coalitions who are multi-sector, we've been able to get these pouches out into the hands of the citizens and organizations that most desperately need them. And the success has been unbelievable. And the reason why we are so pleased to be a part of this effort is that, as most of you know, that about 60% of the opioids that are abused, still today, they get them from families and friends and relatives. And we know from FDA that about 50 to 70% of all the medicines that are written in the form of prescriptions go unused. So there are lots of medicines that need to be taken out of homes, and we are very, very pleased to be working with CPOP and with MEPCA to make that happen. And I am extremely pleased to be a part of this webinar, which is talking about reducing the misuse and diversion of excess medicines in homes across the United States. And I would like now to turn the mic over to my dear friend who was there with us from the very beginning when we joined together to create CPOP, the Honorable Mary Bono. And it is now using her skill and leadership to grow and develop MEPCA into the organization that it has become. Mary?
Thank you, General Dean. And thank you to all of you who are on the line today and for all the great work you do in this space. Mothers Against Prescription Drug Abuse was founded in 2011, back when I was a sitting member of Congress, by 3 mothers who each lost a son to a prescription opioid overdose. We rallied together. You might know that I had a family member who is going through the opioid crisis himself, and he's in recovery now at the age of 31. But I spoke publicly about our family struggles, and that sort of made us, me or us, beacons of hope for other people going through the same thing. So our main focus has been to try to provide scholarships for students in college who are in recovery. Of course, COVID has changed this and made things quite difficult, so we've switched our focus and tried to adapt to this new environment. We all know that the difficulties and the unique and serious challenges that we're facing by this epidemic during this pandemic, and of course I mean the opioid abuse epidemic during the COVID pandemic, that we have a lot of new and very serious challenges. All of us on the line who are advocates or government workers or everybody were thrilled. A year ago, we thought we were turning the tide. The numbers were changing. They were reversing. Things were going in the right way. And as we all know now, it's sad to say that the numbers are ticking up and that things are getting worse. So I just want to thank you all. I want to thank all of the members of CPOP for partnering on this webinar series. We did believe it was a very important opportunity for us to continue to educate and raise the awareness about all its unique challenges. I just want to thank General Dean for his leadership. I get to serve with General Dean as a board member of CADCA. It's a real pleasure. But I also want to thank Admiral Winnefeld for joining the call today. Just briefly, I cold called Admiral Winnefeld one day to ask if I could partner with him or help them or do anything. And I didn't realize that our paths had crossed while I was a member of Congress. I was actually lucky enough to be on his boat, which is called an aircraft carrier, the USS Enterprise. He's a very decorated hero in America, and I'm just thrilled and honored that he'd be on the line for today's call. And with that, General Dean, I'm happy to yield back to you.
Well, thank you, Mary, and we appreciate you and your leadership as well. So thank you so much. We are set to wrap up our four-part series today at the end of our healthcare delivery system, addressing, as I mentioned earlier, unused and unwanted prescription opioids kept in homes. We are here from an impressive series of national leaders this afternoon around this collective effort to address this threat and mitigate risks posed by drug remaining in the home over a prolonged period of time. Helping us to moderate today's CPOP leader is a leader in CPOP and in her own right, the co-chair of the Safe Disposable and Anti-Diversion Work Group. One of the very important work groups within CPOP is Judy Lawrence Person. Judy currently serves as the Vice President of Regulatory and Compliance for the National Hospice and Palliative Care Organization. Julie serves as a key contact with the Centers for Medicare and Medicaid Services, interfacing with hospice payment policies, Part D, survey and certification, contractor management, and program integrity functions, among others. She also represents hospice and palliative care with the GAO, the DEA, and the Medicare Administration contract, and other federal agencies and many national organizations. She graduated with honors from the University of North Carolina at Greensboro with a degree in sociology and has a Master of Public Health from the University of North Carolina at Chapel Hill. I present to you our moderator for today, Judy Lawrence Person.
Thank you so much for that kind introduction, General Dean. I'm so pleased to join today's discussion in this capacity, recognizing the immense importance of addressing the threats posed by unused and unwanted medications in the home. Often these are diverted or abused by friends and family members. The Support Act for Patients and Communities, passed in October of 2018, set forth several initiatives aimed at better understanding drug disposal and its utilization throughout the healthcare industry. These provisions called for greater studies around in-home disposal for hospice programs, which we'll hear more about shortly, and efforts to improve opioid packaging, storage, and disposal through the REMS program. These ongoing efforts are important to flag given the need to address drug take-back and disposal during the coronavirus pandemic, where our access to healthcare services and related care sites is limited. It's now my distinct pleasure to introduce a long-standing friend to CPOP and fierce leader in the national response to the opioid epidemic. From the Office of National Drug Control Policy, Dr. CZ Spitsnaz serves as a senior science policy advisor, where she provides policy analysis and scientific advice to the ONDCP director and chief of staff on special matters of concern to ONDCP, such as emerging drug trends and demand reduction, and helps to develop legislative responses to problems of national scope, particularly on prescription drugs, heroin, and fentanyl. Prior to joining ONDCP, she served as a program official at the National Institute on Drug Abuse, where her research portfolio concerned developing and testing new screening, brief interventions, and treatments for people with substance abuse disorders, including pregnant women, and developing provider training. She received her clinical and research training in psychology at the University of New Mexico and the University of Alabama at Birmingham School of Medicine. CC, thank you so much for joining us today. The floor is yours.
Thank you very much for that kind introduction, Judy. And I would like to thank the Honorable Mary Bono and General Dean, and also the members of CPOP and MADPA for working on this very challenging issue. And thank you to all the guests who you've invited today for taking the time to be here. This topic is important to so many families and so many coalitions, and we really appreciate your work in this area. I know some of you heard from my boss last week, but for those of you who did not, I would like to take a few minutes to offer just a few words about what our office, the Office of National Drug Control Policy, does, or ONDCP. ONDCP was created by Congress to do three things. First, we make policy. We develop the President's National Drug Control Strategy and other policy plans as needed. For example, last year we published a treatment plan. Second, we coordinate the federal interagency's implementation of the National Drug Control Strategy. And third, we ensure that through our Budget Oversight Authority, federal agencies have the funding to carry out the goals and objectives of the National Drug Control Strategy. Some of you may have heard that our agency director, Mr. James Carroll, recently reorganized our agency, and now our education, prevention, treatment, and recovery efforts are fully integrated into our coordination groups. ONDCP is divided into two coordination groups. I am now part of the Opioids and Synthetics Coordination Group, and our other coordination group is the Cocaine Coordination Group, which also handles marijuana. Prescription medications are generally the drugs that people are interested in disposing of, and so our group has responsibility for prescription drug disposal and also responsibility for safe storage. Next slide, please. So today I'm going to discuss the National Drug Control Strategy priorities related to this webinar's topic on safe storage and disposal. At the heart, the central goal of our strategy is to prevent people from dying. And there are specific efforts aimed at this within the strategy that are relevant to storage and disposal. I'm going to talk about two of them today. First one is safe prescribing. By now, you probably all have heard that our prescription drug issues and diversion became such a problem because of excess availability and people obtaining unused or unwanted medications from friends and family. In some cases, these drugs are taken without permission. So discussing safe storage and disposal are essential activities for providers. Handing a patient a medication or a prescription without having a conversation about safely storing it is unlikely to prevent this problem. I even have a personal story about this. My ex-husband and I had no children and rarely had people over, but we had a dog sitter who was very responsible, who worked for a company. One day she had to go to her mother's funeral, and she called the company, and the company sent a 16-year-old into our home to take care of our dogs. The story has a bit of a tricky ending. The 16-year-old was fine. She tried to do her job. And then I realized that the company that worked for us was not licensed, bonded, or insured for a 16-year-old to come into our home. I complained to the owner and she replaced the girl. But the company owner had a key to our house. And it turned out that she got caught taking oxycodone at another house that she served on through her client's nanny cam that was set up in the kitchen. We only found this out when the owner was due to go to trial and local police advertised for other clients to check their home's medicine cabinets to see if they were missing medication. So we were two grown-ups, and I worked for ONDCP at the time, but I hadn't really thought about whether I should secure any leftovers because we were two adults living by ourselves. And my husband had had a skiing injury that year. To this day, I don't know if he took the OxyContin and took all of it, or if the 16-year-old took some of it with her, or if the company owner accessed our house and took it. Unfortunately, she ended up losing her entire business. And I always think that it could have been much worse. At least there was no overdose. Needless to say, I firmly believe that a conversation with the provider is in order to ensure safe prescribing and that all adult family members should typically be involved in this conversation. Patients are not necessarily in a good position to monitor their own medications. And likewise, just handing a patient a means of disposal is not enough. People need to know what the substances they are receiving are and that they could be deadly if misused, or not just the person who to whom they are prescribed needs to know this information. So in addition to safe prescribing, the National Drug Control Strategy also focuses on drug take-back. So in terms of improving drug take-back, we are interested in a variety of topics related to that. I have to make my screen bigger to see my writing at this point. Does it want to be bigger? And move in. In terms of, in 2010, DEA's disposal statute regulations allowed for family members or hospice caregivers or the end user to take medications back to either a law enforcement agency or a participating pharmacy. And not all pharmacies participate. I'm going to get to that in a minute. They also permit return by mail. and they are silent on the means of disposal by the end user. They do not contain a standard for disposal by the end user, which is important. They regulate, these regulations regulate pharmacies, law enforcement, collectors, and hospice. Pharmacies and law enforcement may return via mail, including through an authorized collector program, and there are many commercial authorized collectors that, and arrangements can be made to pick up medication through them, either through a box that you send back, or they will even arrange to come for a fee and pick medications up. So we are concerned also about safe storage and disposal during COVID. We know that DEA was forced to postpone their take-back day that would have been this past spring, and we have concerns that medications may not be going back from law enforcement facilities or to pharmacies as regularly as they had when there was a DEA take-back. I actually got a call from my best friend this weekend who is down in a tiny town in Arkansas disposing of her grandfather's estate, and her grandfather was a physician, and there were bags and bags of leftover samples and different kinds of medicines going all the way back to World War II in his home. And they had a problem trying to access the local sheriff because there was so much already in the box that they were unable to take it back there. But we were able to find them a resource through a local pharmacy. They did have to drive 43 miles in order to use it, though. So, you know, we are concerned about access during COVID. We know now that the next DEA Take-Back Day is planned for October 24th. It may not look like a traditional Take-Back Day. It might be something like a drive-by Take-Back Day, but that will be happening. And there are 3 resources that I want to mention: that the Remove the Risk Toolkit, the Up and Away Toolkit, and the Centers for Disease Up and Away, and DEA also has a Secure Your Meds campaign. And I think there is a repeat in here. I'll fix this slide and get it back to Matt. I also ended up using a very helpful tool that I don't have on here that is on the DEA's website for helping my friend locate a pharmacy. But in addition, even though the National Drug Control Strategy talks about take-back, you know, like it's Take-Back Day, we want Take-Back ultimately to be able to be every day. And I'm one of those people who's terrible at bringing back anything, bringing back Tupperware, bringing back a library book. I'm just bad at it. So, you know, we really, you know, like the fact that there are some at-home options, and there need to be more at-home options. One at-home option or near-home option would be a mail-back envelope, but there are also some products that are able to bind drugs. And the San Francisco Health Commission, Health Department commissioned a report on the research behind these different systems, and it's available at Medicine Disposal Products, an overview of products and performance questions. I'm going to send that to Matt as well, so he can send it out to participants afterwards. And just so people are aware, neither FDA nor DEA regulate these products. They don't regulate the end user's behavior, as I mentioned earlier. So, so they're essentially silent on these. And then finally, you know, ONDCP's position that is outlined in the National Drug Control Strategy is that these products should be more widely available. So if you have a need to get in touch with me, here's my email address, and thank you very much for allowing me to participate today.
Thank you so much, Cece, for your remarks. We appreciate your ongoing leadership and enthusiasm and passion at the national level. Your partnership with CPOP and MAPTA can't be understated. We appreciate you joining us this afternoon and for staying on the line to answer some questions at the end of our webinar. So now we're going to turn to a panel of other national leaders on a variety of perspectives on this topic. And they will expand on what we just heard covered by our colleagues at ONDCP. We're going to hold the questions until after our 3 speakers have completed their remarks. At any point, you may submit a question through the Q&A tool on the left-hand side of your screen. We will do our best to get to each question, but we'll gladly follow up on individual items in the instance when they're not addressed. First, we are thrilled to hear from Admiral James Winnefeld of SAFE Project. SAFE Project was founded in November of 2017 by Admiral Winnefeld and his wife, Mary, following the tragic loss of their 19-year-old son, Jonathan, to an accidental opioid overdose. Admiral Winnefeld graduated from Georgia Tech with a degree in aerospace engineering and served for 37 years in the United States Navy. He retired in 2015 after serving 4 years as the 9th Vice Chairman of the Joint Chiefs of Staff and the United States #2 ranking military officer. We're thrilled to have him join us today for this important dialogue. With that, Admiral Winnefeld, we're pleased to turn the webinar over to you for your remarks.
Thank you, Judy, and thanks to the leadership of CPOP for your important work, and also thank you for including me in today's event. As Judy mentioned, my spouse Mary and I are in this business because we lost our son to an accidental overdose of fentanyl-laced heroin on his 4th day as a freshman in college. He had long suffered from anxiety and depression and had turned to drugs to help bring him down from a prescription of Adderall that had been given to him for a misdiagnosis of ADHD, which is another problem we should consider someday. He spent 15 months in treatment for what we thought was alcohol, marijuana, and Xanax and was doing great. While in treatment, he'd achieved his EMT qualification, wrote an amazing freshman essay about his recovery experience, and was looking forward to going to college and working as an EMT on the side. But the opioid molecule was just too powerful, and it claimed him in his dormitory room. And in the aftermath of our loss, we decided to start a national nonprofit, which we call SAFE Project, which stands for Stop the Addiction Fatality Epidemic. We say John lost the battle, but he's going to help us all win the war. We originally organized around the 6 things we think our country needs to do. One being public awareness, a second being prevention, a third being prescription medicine and medical response, a fourth being law enforcement and justice, a fifth being treatment and recovery, and the 6th being family outreach and support. There's no single lever we can pull to reverse this crisis, and all 6 of these things are dependent on each other. As we do our work, we have 4 audiences: campuses, communities, veterans, and now workplaces. And thanks to our donors and an incredibly talented and dedicated staff, we think we're making a difference, including today's topic of trying to get prescription drugs under control. And we're trying to do it in the midst of COVID. This epidemic of overdose fatalities is not going away. And with addiction being joined at the hip with mental health, COVID has only made it worse. The increased stress levels due to both the disease itself and its effects on the economy and the impact of social isolation has only increased mental health challenges. So the number of people suffering from substance abuse disorder has increased accordingly, and life is far more dangerous for those who were already suffering from it. In turn, as General Dean pointed out, we have seen a commensurate increase in fatal and non-fatal overdoses. It's our understanding that nationwide overdoses were up a whopping 42% in May alone. The Cohen Veterans Network reports that 20,000 new veterans are suffering with SUD since the start of the pandemic. And every 1% increase in unemployment has historically equated to a 3.6% increase in the opioid death rate. So you can do the math on that. So here are a few statistics regarding why SAFE got involved in helping people more easily get rid of their prescription medicines, particularly pain relievers. We all know 3 out of 4 people addicted to heroin started with prescription drugs. 2 out of 3 people abusing prescription drugs got them from a friend or relative. 1 in 3 Americans have unused prescriptions or expired over-the-counter medications in their homes, and most want to be part of the solution to that problem as long as they are aware of it. Of the 1.4 billion opioid prescriptions dispensed from 2012 to 2017, we know that up to 70% of those prescribed for post-surgical use were unused. And every day, 2,500 kids abuse a prescription pain reliever for the first time. The #1 place high school students get prescription drugs is from their parents' and friends' medicine cabinets. And we also know that disposal needs to be convenient. Less than 15% of patients given information on drop-off sites actually dispose of their drugs that way. So here's what we did. In addition to our Be Safe campaign, which has put signage in hospitals, shopping malls, bus stops in 3 major cities, and soon in Baltimore Washington Airport, which urge caution using prescription medicine, we also strongly support safe disposal. After the annual spring DEA Drug Take-Back Day was canceled due to the pandemic, Safe Project partnered with Deterra to launch the Gone for Good campaign during April and May of this year. During this campaign, we were able to educate people on the importance of safe storage and disposal, and even more importantly, with Deterra's strong support, we were able to give people access to convenient and effective at-home deactivation and disposal pouches that could easily be requested online and were mailed directly to their home in early June. As a result of the Gone for Good campaign, Safe Project and Deterra distributed over 10,000 disposal pouches across the United States, nearly doubling our initial goal and reaching homes in 46 states plus Washington, D.C. Now, we don't have a direct measure, but this campaign offered the potential to get rid of nearly 1 million unused prescription or over-the-counter medications, including pills, creams, patches, liquids, and films that were destroyed permanently, eliminating a huge number of opportunities for drug abuse, misuse, diversion, and accidental poisoning. Now, Gone for Good is a great example of an at-home deactivation and disposal initiative that the DEA could offer in tandem with its regular biannual Drug Take-Back Day programs, especially in light of the ongoing pandemic. This project worked very well for us, and we need to do more of it. Safe Project's looking forward to continuing its partnership with Deterra in the fall of this year with a goal to distribute to even more households in the U.S., and we hope we can find strong support from this group. And I look forward to the questions, and I will now turn it back to you, Judy. Thank you very much.
Thank you so much, Admiral Winnefeld. Very important information, and we appreciate your focus on this and your continuing dedication to addressing the opioid epidemic. We all know how important it is to get those unused and unwanted prescription drugs out of the home. And then certainly the panelists today are all with you in that very important message. We're now going to turn to our 2 clinicians on the panel for further discussion of the clinical implementation of such practices, especially during the pandemic. Up first is Dr. Doug Thornton from the University of Houston College of Pharmacy. Dr. Thornton serves as an assistant professor of pharmaceutical health outcomes and policy and is the co-director of the Prescription Drug Misuse Education and Research Center, or PREMIER. He is a member of the American Pharmacists Association and the American Association of Colleges of Pharmacy. Dr. Thornton practiced as a board-certified clinical pharmacist while completing his PhD in Health Services and Outcomes Research at West Virginia University. Before completing his PhD in 2017, he graduated from the West Virginia University School of Pharmacy with a professional pharmacy degree, PharmD, and completed a postgraduate 1-year pharmacy practice residency at St. Mary's Medical Center in Huntington, West Virginia, where he saw opioid abuse destroying lives and families firsthand. We're so happy to have you, Dr. Thornton, join us this afternoon. Please go ahead.
All right. Thank you very much for the wonderful introduction, and thanks to the leadership team for inviting me here today. We're going to be talking about safe drug disposal in Texas and how we've adapted 2 statewide projects with the ever-changing realm of COVID-19 in Texas. All right. So as we know, a significant part of prescription drug misuse can start close to home. Nationally, 11% of high school seniors reported non-medical use of prescription drugs. And according to the Texas School Survey, which is a statewide survey here in the state, about 12% of high school seniors reported the same non-medical use in Texas, and that number was even higher in the Houston area. The most common source for the 12 to 17-year-olds were friends, family members, and personal supply from leftover previous fills. There are, as we talked about today, Cece, I believe, brought it up, there are 2 broad types of what we have called single-use disposal systems, or SUDS. And in 2020, earlier this year, we published in the Journal of the American Pharmacists Association a review updating that report from the San Francisco Department of Health, where we've delineated the deactivation and incineration types of single-use disposal systems. We'll talk about the use of both of those in the next couple slides. So there again, as I mentioned, there are two large projects here in Texas that have been funded with either the Strategic Prevention Framework for Prescription Drugs, or SPIF-RX, which is a program that was funded from SAMHSA from 2016 to 2021. And then there is the state opioid response, and one of the projects that we're working on here in the University of Houston is the Safe Drug Disposal and Community Awareness Project of Texas's SOR funding called Texas Targeted Opioid Response. So again, that funding was from SAMHSA, the Texas Health and Human Services Commission, and then to us here at the University of Houston. The SPIF-RX project we've called Educate Before You Medicate. The goal is to train community organizations across Texas to effectively communicate with pharmacists and community pharmacists, because we identified them as being some of the most important advocates for prescription drug misuse prevention in the community. The pharmacist-facing education would focus on, or has focused on, prescription or safe drug dispensing, disposal, prescription drug monitoring program use, and referral options. The goal of this broadly is to prevent prescription drug misuse and excess medication dispensing, as we brought up, many of the speakers today have mentioned. The other project is the Texas Improved Dissemination and Evaluation of Single-Use Disposal Systems, or TIDES, working with stakeholder groups throughout the state that are primarily driven by the Substance Abuse Block Grant funded community coalition partnership groups, prescriber groups, and other community groups. We have distributed over 150,000 single-use disposal systems of either the incineration or the deactivation variety. And we'll talk about some specific numbers post-COVID as well. The goal of this project has been to remove unused and expired medications from the home. So both of these projects are very much in line with today's presentation. So a brief overview of EBYM, the training of community pharmacists. We identified the pharmacists play a major role in impacting patient education because of their accessibility to those in the community. Community pharmacists sometimes are seen 10 times more often than a primary care provider. This training aims to prepare community members to visit pharmacies, effectively engaging with their community pharmacists, and to act as a resource to help prevent prescription drug misuse. And a couple samples of our materials are shown here. We created a pharmacist pocket card that will help remind the pharmacists all the key points that we've discussed. In a brief overview of the TIDES project, we have a wide variety of data collection that goes along with overseeing and monitoring such a large and diverse group of organizations that are dispensing. And so, as Admiral Winnefeld mentioned, that kind of end measure has been something that I have been interested in since we started working with Texas Health and Human Services Commission, is to identify and evaluate what those end results actually are. And so we monitor the prevention activity tracking for every activity done in the state where one of our pouches or systems has been distributed in any way. We have statewide virtual town halls to gather feedback and disseminate project changes. And then we have semi-structured interviews to evaluate the feasibility and dissemination efforts. And then finally, we collect end-user information to identify the ratio of controlled substances disposed of compared to other non-controlled medications. And briefly, early COVID-19, and I put that in quotes recently because Texas seems to be continuing the COVID-19 longer than some of the other states in the country. We did some research using the prescription drug monitoring program here in the state. Controlled substance prescribing landscape changed significantly in Texas between March 2020 and May 2020 as a result of COVID-19 and the related policy changes. Patients filling opioids went down, prescribers prescribing opioids went down, and that's also true for benzodiazepines and prescribers of benzodiazepines. And so we worry, and again, we're collecting data, or we will have data collected via the PNP to analyze some of these, but we worry that with a decrease in the access to new medications, could non-prescribed use of these medications become even more likely. And unfortunately, we're still we still have to wait and see as a lot of these projects move forward. And so just briefly, I want to go over the adaptations we've made post-COVID. So in addition to the COVID-19, the DEA National Take Back Day was also canceled, as we've previously discussed. So there was a need for responsiveness and adaptation. So the EBYM had a COVID revision where we have identified and realized that community pharmacist prevention priorities have changed significantly. So we developed a training, interview script, and online data collection instrument to assess the patient care needs of community pharmacists, describe the impacts on patient counseling, and to establish distribution mechanism of safe disposal options and to distribute those SUDs in the communities where they're most needed. There's also an expansion of TIDES, where the patients are in their homes now more than ever, many with young children. And so there's a need for safe drug disposal is heightened. The community organizations that we've worked with, over 60 of them in the state, have increased their reach. And now they have made these SUDs available through law enforcement, local health departments, school systems, fire departments, and even others who work with food banks, community clinics, and hospice houses. And so as of last month, we haven't updated the report quite yet for this current month, but about 21% or over 11,000 single-use disposal systems have been distributed after the start of COVID. So these community organizations that we work with have done an amazing job adapting to COVID and have been hosting social distancing appropriate events to help the communities in the most need. And so real quickly, I'd like to thank the two main colleagues on this grant at Texas Health and Human Services Commission, Casey Strike and Lisa Ramirez, as well as my University of Houston team, Danielle, Matt, and all the wonderful students, and Jessica. And so just to mention, both of these projects are funded by SAMHSA via the Texas Health and Human Services Commission. I'll be happy to take questions after this.
Thank you so much, Dr. Thornton. That was very interesting. We're quite interested to hear your results as you keep on working in the Houston area. So finally, we'll hear today from Dr. Bernice Burkhardt regarding her experiences with disposal in the hospice setting. Dr. Burkhardt, I'm so glad you're here. You've been practicing hospice and palliative care since 2005 and currently is the Chief Medical Officer of Merrimack Valley Hospice. She earned her medical degree at Temple University School of Medicine in Pennsylvania and completed her residency in neurosurgery at Albany Medical Center in New York. She obtained Hospice Medical Director certification in 2014 and AAHPM, American Academy of Hospice and Palliative Medicine, fellowship status in 2017. She has served as the chair of the NHPCO, National Hospice and Palliative Care Organization, Physician and Advanced Practice Provider Community Steering Committee since December of 2016. Dr. Burkhardt, we're so glad to have you. Please go ahead.
Thank you, Judy, and good afternoon, and thank you to the leadership of CPOP and MAPTA for the series and for including me in this panel. So, as introduced, I'm providing the perspective of the hospice provider and the hospice community. And I can tell you that those of us in the hospice community remain keenly aware of the issues surrounding potential diversion, misuse of controlled substances, particularly opioids, and remain firmly dedicated to doing our part to diminish the potential for that risk. Of course, part of that includes avoiding having excess medications in the home. We're in a fairly unique situation in that patients admitted to hospice care frequently require intensive medication management of both chronic conditions and symptoms associated with end-stage disease. These symptoms often require the administration of opioids and other controlled substances, which play a key role in alleviating pain and suffering from those with advanced illness and at the end of life. And coincidentally, most patients get hospice care in the home setting because of multiple factors, including changing dosing regimens to meet the changing needs of the patients, as well as prognostic uncertainty in hospice. Many patients do have unused medications at the time of their death. Those medications include opioids or other controlled substances with, of course, the potential risk of diversion and misuse by anyone with access to them. So we know how important this is and what an important role we play. So what do we what role do we play? There's one of action and also advocacy, and part of that includes the support of the Support Act, which was mentioned earlier today. And prior to 2018 and the passage of the Support Act, hospices were limited to providing education and guidance on the disposal of unused medications in the home after a patient death. And since the Support Act has a provision which, though not requiring, does now allow certain hospice employees, including physician assistants and nurses who are employed by the hospice, or physicians who may be employed by or contracted with the hospice, to handle controlled substances in the home setting, on site, in order to assist with patients and families with the disposal of those medications after the death of the patient or if the medication is expired. As long as those individuals, the professionals, are acting within the scope of their employment and have completed a hospice program training regarding disposal of controlled substances in a secure and responsible manner. So at this point, we know that hospices, though not required to, are able to allow qualified employees to assist families with disposal. So what are hospices required to do? We are required to have written policies and procedures for assisting in the disposal of controlled substances, and we must not only have them, but provide them to patients and families at the time that controlled substances are first ordered. Furthermore, hospices are required to discuss the policies and procedures with the patient and family in a language and manner that they understand in order to ensure that they're educated regarding the safe disposal of controlled substances. And then we must document, of course, that in the patient's record that the policies and procedures were provided and discussed. And ultimately, following the disposal of these controlled substances, the hospice must again document in the patient's clinical record the type of controlled substance, the dosage form, whether it's a tablet or patch, etc., the route of administration, the quantity disposed of, as well as the time, date, and manner of disposal. Now, one of the challenges in the Support Act is that it is a federal law, and there can be state or local governments that have additional controls or restrictions relating to the regulation of disposal of controlled substances. And that applies to hospice care and hospice programs. So hospices will often want to contact their relevant state agencies and or the DEA office in their state for that guidance. That's one way to mitigate that challenge presented by the differences, if you will, in federal and state laws. And a rule of thumb has been to follow the more stringent guideline. Following the Support Act, the Government Accountability Office conducted a study from April 2019 to April 2020, which looked at selected home hospices' controlled substances disposal practices and the challenges they faced in disposing of these substances. And what they found is that hospices have indeed developed and identified best practices for preventing this diversion and for expediting the disposal of controlled substances. And of course, included in preventing diversion is avoiding excess medications in the home. So I generally group these into three categories: before prescribing, during prescribing, and after the death of the patient. And you'll note that the measures are not limited to their specific category, but can be used throughout the care and course of care as appropriate. So before prescribing, assessment of the home environment, typically first done by the admission nurse, who is the first member of the hospice team in the home, and also as part of the interdisciplinary comprehensive psychosocial assessment. Hospice clinicians will actually screen for a history of addiction, risk of misuse diversion within the home, including the patient, family, caregivers, other residents, and frequent visitors. And if there is any potential risk identified within the household, providers work with the family to develop a very specific plan of care for that patient and family with risk mitigation strategies, some of which can include the use of medication management agreement or controlled substances agreement. These typically address the process whereby controlled substances will be managed safely, including safe storage and safe disposal, as well as the expectation for disposal after the death of the patient or when the medication is expired or no longer necessary, and looks at restrictions on prescribers as well as restrictions on early or after hour refills of medications. Risk mitigation strategies also include the use of lock boxes to limit access to controlled substances in situations where diversion may be suspected to be a risk, or if there are children present in the patient's home, as has been noted in several of the earlier examples. There are also safe prescribing practices that can happen before prescribing. As mentioned earlier, checking the state prescription drug monitoring program, as well as utilizing and implementing opioid risk assessments, of which there are various validated tools available. Education to patient and family regarding controlled substance use and disposal should begin on the patient's admission as per the Support Care Act, and this would include medication management strategies, not just storage, but why a medication is ordered in the amount it's ordered, why the expectation is that once that medication is no longer utilized, that it would be discarded in a safe fashion so that it is unusable by anyone else. During prescribing, there are prescriber practices and pharmacy collaborations. As I mentioned earlier, there's a lot being done in Texas, and a hospice specifically may choose to have the pharmacy mail or deliver a prescribed controlled substance in smaller quantities with greater frequency, as often as daily if needed, if they're to reduce any risk of controlled substances being diverted and to reduce the risk of developing and having excess medications in the home. COVID has impacted this. Attempts to decrease the traffic in the patient's home, decrease contact, and decrease exposure may limit this endeavor. For example, at our hospice, we had arrived at a 5-day quantity for medications to be able to manage changes in the medication regimen and to limit excess medications in the home. However, with COVID and the decrease in the delivery numbers, that has expanded again to 10 to 14 days. So we keep an eye on the status of the COVID in our communities to try and return back to the more frequent, smaller quantity prescribing of medications. And also collaboration with the pharmacy in noting when a refill prescription is requested sooner than it should have been and alerting the hospice to that is a way to mitigate the risk of potential abuse and or excess medications in the home. Prescription drug counts performed by hospice employees at every visit to determine if controlled substances are being used properly and to determine the need for refills at the appropriate time, maintaining that balance between the need for patients to have consistent symptom control while avoiding having excess medications in the home. And there's education to the staff on how to identify potential diversion, which substances are most likely to be diverted, and what to do in cases where diversion is suspected, confirmed, and identified, including very clearly written agency policies and procedures that can be tailored to the patient's specific needs and context. Now, at the time of death, as discussed earlier by Dr. Spitzner and others, there are take-back programs, including permanent collection locations, with pharmacies and local state enforcement agencies participating, as well as medication mail-back programs and the DEA-sponsored National Drug Take-Back Days. There are in-home disposal products, as mentioned earlier, various consumer commercial medication deactivation and or destruction products, which may be utilized to dispose of medications. There are some challenges involved with that. In some cases, they may be cost prohibitive to a hospice. In one hospice in the GAO study, they were able to fund this through a grant. And as you heard earlier, there are partnerships developing as well within communities that may make those more available. And those are typically pouches or containers that have materials that will deactivate or destroy the medications, making them completely unusable. Ultimately, we may have to, if the drug take-back program is not available and there are no commercial products, at-home disposal. And that is guided through the DEA website, which actually directs you to the FDA website, where they explicitly instruct on removing the drugs from the original containers and mixing them with an undesirable element, coffee grounds, dirt, or cat litter, with water in a sealed or resealable container to prevent the substance from leaking out, and then throwing that container unmarked into your garbage and then ultimately into the trash. There is a note that some medications could be especially harmful to others and in some cases fatal with just one dose if they are used by someone other than the person for whom they were prescribed. Those medications often have specific directions where if a take-back option is not readily available and the medication must be removed from the premises to be able to destroy them through the FDA guidance, and they have a list of medications for that specifically. Challenges with at-home disposal include having a witness for the disposal of the unused controlled substances. That can be either because there's not another person there or because a family refuses to participate in the signing. That can be mitigated by assigning 2 staff members at the time of disposal of medications, and then ultimately family refusal, which can be mitigated by mitigated by early education on the expectation for removal or for disposal of those medications. I want to be clear that the hospice staff will not be removing the medications from the home. This is on-site disposal for which we've gotten assistance with through the Support Act. And I will close now and answer any questions at the close of the program. Thank you.
Great. Thank you so much, Dr. Burkhardt. I'd like to now turn us to some questions from the audience, and I'll get us started while you join and put some questions into the Q&A part of the webinar screen. So this is for any and all of you. We recognize that the development and availability of products to dispose of unwanted or unused prescription drugs is important. However, change will only come when there is a shift in consumer behavior. In your practice, have you seen any evidence of this? Maybe, Doug, you could take that one because you've done so much work in the community in the
Sure.
Houston area.
Yeah. So we did a study where we looked at before we even started any of this distribution. We did a study looking at, well, are patients even willing to dispose of their medications? And the answer, at least preliminarily, was yes. They're about twice as likely if they're discussed at time of dispensing or prescribing about disposal options and why disposal is needed. They're more likely to dispose of their medications, which, again, good sign for us. That was why we moved forward with some of the things that we have. And again, I think that post-COVID, there have been such an increased urgency from some of these people that have more family members at home than they ever had in the past, to be honest.
Right.
A lot of intergenerational. Yeah. So, yeah, definitely. Short answer. Sorry.
All right. Thank you so much. So, Dr. Spitsness, from a national perspective, how is the administration working to augment the efforts of the DEA through the National Drug Take-Back Days? And what in particular could we help with for individuals in rural areas or who have limited access to health care and may not be able to dispose easily of unused or unwanted drugs?
Thank you for that question. So there are three programs in my slides that discuss what can be done. You know, I think one thing is hold on to them until it's available again, if that's feasible, but have them be stored appropriately so that, you know, somebody who might enter your house or a child or a teenager would not be able to obtain access. And then, you know, looking at availability of alternatives to the take-back day, whether that be a single-use disposal option or something, you know, like if you're for example, law enforcement agency and you have them piling up, trying to work initially with an authorized collector to get them taken care of. And the other thing I just wanted to mention is that, you know, I talked about the friend who was having trouble getting rid of these things. She was relatively sophisticated because I had talked to her about this a lot. And but a lot of people still, I think, don't realize the importance of it. And one thing, she was interested in trying to obtain a bag, but she only had a limited amount of time. And so trying to have you know, awareness if you're in the, you know, if you're trying to do an estate clean out, for example, that you're going to need to order these things in advance, allow time for shipping. The shipping right now may be kind of delayed. And then a final thing is that we've got there is a grant program. It's closed for this year, but for next year, just so people are aware, I believe it will cover 25 different states getting extra funds for disposal, and there have not necessarily been sufficient applications for that each year. So I will forward CPOP some information about that program, but it is specifically so that you know, states can get funding to augment their disposal budget.
That's a really great information. Thank you so much for that. It's been such a pleasure to have all of you with us today. So, General Dean, I'll turn it back over to you for your concluding remarks.
Judy, thank you for hosting us today and being such a great moderator. We appreciate it. And many thanks to CPOP and to MAPCA for sponsoring this series. And I think we are ending on a very, very important one. We heard from our speakers today, and several of them talked about the extended number of days of medications that patients are being able to have now as a result of COVID-19. We all know from the data that we've heard today and what we get from FDA and others, to include CDC, that there is a problem with unwanted and unused medicines. We know from what we've heard from our speakers that most of the people that abuse these medicines get them from families and friends. Therefore, we do have a lot of work to do, but it's great to hear that so many wonderful initiatives are taking place. So I would like to thank all of our speakers, those that provided great insight today as well. And we look forward to continuing to work this issue because clearly, there's much to be done. So thank you all very much. Matt, do you have any administrative instructions you need to pass before we conclude?
Thank you, General Dean. Simply just want to note that a recording of today's webinar, along with the previous 3 sessions, will be made available to all registrants and posted both to the CPOP and MAPTA websites. So please feel free to share that content amongst your organizations and allies. And you'll also be receiving an email shortly from our team with a link to the recording, the slide deck, and related documents that were all posted within the Resource Center. That should be going out later today. But with that, just want to once again thank everybody for joining us and for participating in the CPOP MAPTA webinar series. As it officially comes to a wrap after 5 weeks, we look forward to working with each one of you and your organizations going forward in terms of developing a comprehensive and coordinated solution to the opioid epidemic, and certainly stand ready to partner on these important initiatives. Should there be any questions or follow-up to either this webinar or any within the series, please do reach out to myself. Happy to answer any questions or coordinate with your organization. But with that, just thanks again. Have a wonderful evening, and we look forward to being in touch soon.